everybody, and thank you for joining me in this short video presentation regarding catheter ablation of atrial fibrillation in a woman with persistent atrial fibrillation. I hope you enjoyed this video and join me in my future presentations. Thank you. Our patient is a 62-year-old woman with persistent atrial fibrillation refractory to medical therapy who was referred to our Center for Catheter Ablation. Female gender is associated with an increased recurrence of atrial fibrillation after catheter ablation. Although atrial fibrillation is more common in men, women constitute a significant proportion with persistent atrial fibrillation. Here we see the baseline ECG, the 12-lead ECG of the patient showing atrial fibrillation. And here we see the atrial activation in the coronary sinus catheter. First, I would like to introduce this important study which recently published in Heart Rhythm. The authors performed a multi-center observational study to determine long-term arrhythmia outcomes in patients undergoing more than one catheter ablation for persistent atrial fibrillation. Catheter ablation in these patients involved pulmonary vein isolation with additional ablation including linear lesions, posterior wall isolation, electrogram guided ablation, or a combination of these methods. A total of 281 patients with more than one catheter ablation procedure for persistent atrial fibrillation were included in this analysis. 86 patients were female. At mean follow-up of 45.5 months, freedom from recurrent atrial fibrillation was present in 148 patients, equal to almost 53%, after an average of 2.2 procedures. In multivariate analysis, female gender with a hazard ratio of 2.1 and sustained pulmonary vein isolation with a hazard ratio of 1.64 were independently associated with recurrence of atrial fibrillation. It's noteworthy to mention that sustained pulmonary vein isolation was significantly higher in women than in men, 34% versus almost 20%. Having the results of this study and other similar studies in mind, I would like to complete the data on her condition before catheter ablation. She had sleep apnea syndrome with CPAP therapy. In addition, her hypertension and diabetes were poorly controlled due to obesity with body mass index of 45 and poor medication compliance. Therefore, we expected a very low success rate with one catheter ablation procedure. But during the procedure, we find something interesting that changed my outcomes estimation, and I would like to share it with you here. During antral isolation of the left-sided pulmonary veins, we observed this tachycardia, which was actually a pulmonary vein tachycardia from left superior pulmonary vein with 2-to-1 conduction to left atrium, mimicking a left atrial tachycardia. Here we see the sinus rhythm determination of the tachycardia after completion of the isolation of the left-sided pulmonary veins. And this tracing shows sinus rhythm with ongoing PV tachycardia, and the white arrow shows the successful ablation site of this tachycardia inside left superior pulmonary vein. So, in conclusion, we know that there is a gender gap and we have to do everything to understand the reasons for it and try to close this gap. In our patient, we estimated a poor outcome, and the findings during catheter ablation improved her chances of freedom from atrial fibrillation dramatically. Therefore, still it's very difficult to predict the outcome in individual patients, and this would be our next challenge, to have a better estimation of outcome, probably by using pre-procedural non-invasive surface mapping and or artificial intelligence to better select the patients and to have a better estimation of their outcomes. Once again, thank you for joining me, and I hope to have you here in my future presentations.